Yesterday we presented the data of Niraparib after frontline chemotherapy for newly diagnosed advanced ovarian cancer patients. So, advanced ovarian cancer is a disease that had a very high risk of relapse at the end of the chemotherapy. Actually, we do have some alternatives for maintenance therapy, but do not fit for all the patients. So there is still a high unmet need for many patients. We already had data on Niraparib after a response in the patients that do have a relapse and do respond to chemotherapy. And it was shown that Niraparib prolonged progression-free survival in all the patients independently of the biomarker status. So the design of the PRIMA ENGOT OV26 GOG 3012 trial was to test if Niraparib after chemotherapy in the frontline also could prolong the progression-free survival in those patients with advanced ovarian cancer at high risk of relapse. How we define high risk of relapse? We included patients with high-grade endometrioid and serous ovarian cancer with a stage 3 that after primary debulking surgery had macroscopic residual disease, or patients with a stage 3 that received neoadjuvant chemotherapy regardless of the residual disease in the interval debulking surgery, or any patient with a stage 4. All patients need to have a response to frontline platinum, complete or partial. And then when those patients finish chemo and the response to platinum has been already documented, they can be randomized 2-to-1 to Niraparib or placebo for 36 months or until disease progression. The primary endpoint of our study was progression-free survival, and it was determined by a blinded independent central review. We performed a hierarchical testing of the primary endpoint, first in the group of patients with homologous recombination deficient tumors, and if that was positive, we did the test for the overall population. What we observed is that the addition of Niraparib after frontline platinum-based chemotherapy reduced significantly the risk of progression by 57%. And there was a prolongation of the median progression-free survival from 10.4 to 21.9 months. As this analysis was positive, then we moved to the overall population, and we observed a reduction in the risk of relapse of the overall population by 38%, and a prolongation of the median progression-free survival from 8.2 to 13.8. One of the strengths of the PRIMA study is that we also perform analysis according to different subgroups according to the biomarker. And we saw similar benefit inside the group of homologous recombination deficient patients for BRCA mutated with a hazard ratio of 0.4 and for the BRCA wild type with a hazard ratio of 0.5. And also we observe a benefit in a group that is of worse prognosis, that is those with homologous recombination proficient tumors. There, the hazard ratio was 0.68. So, in terms of safety, the PRIMA study was consistent with prior data on the use of Niraparib, and based on these results, we can conclude that the addition of Niraparib after frontline chemotherapy in patients with advanced ovarian cancer should be considered a new standard of care for the patients.